So the oncolytic virus therapy is actually not a new idea. I would like to remind the audience that the first viral infection-induced tumor regression in patients with leukemia was actually described in 1904, and that various types of tumors were injected and infected with various viruses with actually some interesting results, including rabies, Newcastle virus in 1964 with leukemia patients, measles, mumps, parvovirus, and that the first clinical trial with engineered virus actually started in 1997, and first virus approved oncolytic virus was in China for patients with nasopharyngeal carcinoma in combination with chemo, and it was the famous H1N1 adenovirus. And of course, TVEC is the modified herpes simplex 1 virus. It was developed in 2003 and 2015. We obtained the first US approval of an oncolytic virus in patients with melanoma. The advantage of the HSV virus over some other classes of viruses could be that pathology is well understood. It can replicate in most dividing cells. It has a large DNA genome where you can insert various cassettes to kind of enhance its abilities. And if there would be ever any problems, you can hold its replication by acyclovir, which is really simple. And it was done just like that. The talimogene laherparivec, or TVEC as we call it, actually was engineered by deletion of several loci to make it actually only replicate in tumors, but not in healthy cells. There was a GCSF cassette inserted to enhance its immunogenicity and some other genetic changes. We actually think that when you inject the virus into the tumor, that you are releasing the tumor-associated antigens, and together with stimulation by GM-CSF, you are actually stimulating the antigen-presenting dendritic cells. And what you are actually doing, as Dmitry Zamarin and Jed Wolchok, at Memorial so eloquently shown, you are actually changing the signature in the tumor to the interferon alpha signature, which is associated with better response to checkpoint inhibitors. So based on this rationale, once the initial groundwork was done, we proposed and started a trial in combination of TVEC and ipilimumab, or CTLA-4 antibody, anti-CTLA-4 antibody. And, to kind of take the antigens, prime the system, and then of course, use the checkpoint to enhance. And in our phase 1b trial, we showed that the activated CD8 T cell numbers increased, and they increased initially after TVEC injection, and even more so after the ipilimumab addition. So based on that, we went to the first randomized ever trial with checkpoint inhibitor and oncolytic virus, which was a very simple design, frontline never treated patients with ipilimumab versus ipilimumab and TVEC. Design actually was a little bit skewed in favor of the control arm, because patients who were randomized to ipilimumab just got ipilimumab, and the others actually started with TVEC for 6 weeks, and then ipilimumab was added. The reason was so we can obtain biomarker data on TVEC only, and then on the combination to actually enhance the biological rationale for the combination. The primary endpoint was investigator ORR per modified immune-related response criteria. And we met that, primary endpoint. It was, and we still are meeting it, 4 years later. The objective response rate, 36% for TVEC, IPI, and for IPI-16. So this is really exciting, because the data shows that these responses are durable, unlike some of the other combinations, let's say with targeted therapies like IDO inhibitor. And the progression-free survival, actually, we, although numerically different, 13 months versus 6.4, we didn't reach statistical significance. And probably part of that is that we actually kind of shoot ourselves in the foot with the 6 weeks actually delay in starting ipilimumab, but it was done for a good reason. And when you look at overall survival, again, numerically slightly better, but again, statistically, it is a wash, and it's not surprising. Recent adjuvant trial, IPI versus Nivo, adjuvant therapy presented by Jeff Weber at ESMO actually showed the same survival. So it could be the sequencing or the summary of all the drugs patients receive, which dictates their overall survival. And actually more subsequent anti-cancer therapy was given to the patients on ipilimumab alone, kind of confirming that hunch. What was really interesting was that although it's exploratory, when you look at PFS for the BRAF wild type, it is actually significantly different than for TVEC IPI than for the IPI. 18 months versus 4.5 months, but it's a post-hoc exploratory analysis. Thus one cannot really speak about it too much, but it's really striking. And on the opposite, is true too for the BRAF wild V600 mutation positive patients. There was no difference actually. TVEC IPI 4.2 versus 6.4 for IPI alone. So that actually is something we should be looking at in the lab and to see what is the IPI difference and the TVEC difference in BRAF wild type versus BRAF mutated type of patients with tumors. Again, this is a trial which was done in frontline patients, and that's a limitation because nobody would use IPI alone in a frontline patients anymore. But perhaps, some of the data coming out, with later lines and more modern and developed, complicated viruses such as Oncoras 167, others, may actually shed more light on this problem. The one trial which is ongoing and may actually have a really striking clinical relevance is the MasterKey 265, which is a combination in frontline melanoma patients between TVEC and pembrolizumab versus pembrolizumab alone, based on the, again, exciting phase 1b data published in Cell in 2018. The trial is fully accrued and we are waiting for maturation of data. So stay tuned for that one, because if that one shows superiority of survival, PFS or other primary endpoint, then we possibly will have a combination to use in our frontline or advanced melanoma patients soon.